This is the Eye and Ear Assessments and Procedures lecture. When we talk about introduction to the eye, we have to talk about not only the anatomy, but we have to talk about the procedures that we would be performing within the eye and the ear. So let's talk about the eye first. Irrigation is a procedure that we do, and basically what we're doing is we're washing that canal with some type of solution, and in the textbook it even says a flowing solution. And then the installation is dropping a liquid into a body cavity, and that is definitely what we do with eyes and ears. It's very important that you do this correctly. If you do it incorrectly, you can cause the patient more pain. So we're going to talk about how to do that here in just a second. So first part of this chapter goes into the structure of the eye. I'm not going to talk and lecture to you about theory like you get in the theory class. So I just really want to talk about the main parts of the eye. You know, that outer layer of the eye, which is called the sclera. That's that tough fibrous connective tissue. Remember that we have the lens, and that's what is responsible for focusing the light rays back onto that retina. Then we have that colored part of the eye, which is typically called the iris. And I always think about how beautiful an iris flower is, and that is how I try to remember the colored part of the eye is the iris. And this actually controls the size of the pupil. So when we talk about dilating a pupil, that's what we're talking about. And then the pupil, of course, is the opening of the eye where we allow light to come in or we don't allow as much light to come in. The retina, this is actually the innermost part of the eye, and what happens here is that the rays of the light and whatever the picture is, that is transmitted back to the brain, so that the brain just determines, hey, that is exactly what I'm seeing. It's a flower. Then one of the things that you'll talk about a lot in the doctor's office is the conjunctiva or conjunctiva, whichever way your doctor wants to say it. But this is the part that is the membrane that actually lines the eyelids, and it covers the front part of the eye. So when a patient comes in and they are diagnosed with conjunctivitis, that's inflammation of that part, we commonly call conjunctivitis pink eye. So that's a good one to try to remember. And that is very contagious, absolutely. As you guys know, I will tell you, stay at home, keep your pink eye to yourself. It is very, 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 very contagious. So let's start out with talking about visual acuity. And basically that term visual acuity means that we're looking at and measuring the acuteness and sharpness of the patient's vision. So how do we do that? We use different instrumentation to do that. But let's talk about the different errors of refraction, which is basically what we talk about as being the problem with our eyes is our vision. So we talk about refraction, and that's the ability of the eye to bend that light that comes in so that it can be focused on the retina. So if we have an error in that, that means that it makes the visual acuity skewed. So when we talk about myopia, M-Y-O-P-I-A, that's one of those vocabulary terms that you should be familiar with. This is when the patient is considered nearsighted. So with this condition, the eyeball is too long from front to back, and it causes those light rays to be brought to a focus in the front of the retina. So they have problems being able to see things at a distance. So if someone is nearsighted, listen again, if somebody is nearsighted, they have trouble seeing things at a far distance. Okay, so looking at hyperopia, this is farsighted. So this is going to be the exact opposite. So with this, they're having trouble seeing things kind of up close, like if you were trying to read a book, look at a computer. It's kind of like that old saying of, hey, my arms aren't quite long enough to be able to see this. A lot of patients are diagnosed with an astigmatism, which is basically a refractive error that makes the visual acuity blurred for both near and far objects. So unfortunately, they have a little bit of trouble all the way around. And then that brings us down to the old eyes, as I like to say. Whenever you hit age 40, your warranty starts wearing out, you start having everything fall apart. But at about age 40, most people develop this condition called presbyopia, where things aren't quite as clear as they used to be. The elasticity of that lens starts to wear out, so we're trying to struggle to see things. We're squinting. Then we start having that problem where our arms aren't long enough to read things. So the next part of the chapter talks about things that we discuss in terminology, which is what is the difference between an ophthalmologist and an optometrist. So remember that optometrist is the one that is specializing in, the eye doctor that's specializing in giving those glasses out to people after they measure their visual acuity and they figure out what strength of corrective lenses they need. Whereas the ophthalmologist, they do the same thing, but they actually treat more of the diseases and disorders of the eyes, and they're the ones that are doing a lot of surgery. So the lens replacement, removing cataracts, those types of things, they are performed by a ophthalmologist. Okay, so how do we measure visual acuity? One of the most common methods of measuring distance, the distance part of visual acuity is with a Snellen Eye Chart. Snellen. And this is one that you're probably very familiar with. It starts with the E at the top of the page and starts going down. You go E, F, P, T, O, Z, L, P, E, D. I have that wonderful chart memorized, but there's also different types of Snellen charts. The one that we use for our school-age children, this one actually is what a lot of people say is the falling E. And if you flip over in your textbook, you can see a good picture of the Snellen chart and the falling E. And I apologize, I am not keeping up with the this PowerPoint. Yeah, I told y'all I struggle with it. So let's start talking about here. Sorry, I'll get to the right page in here in a second. Okay. So conducting the Snellen chart, basically what you have to remember, and this will be familiar because you've used this thing before, and there is one hanging in our clinical lab. The patient stands at a distance of 20 feet from the Snellen chart. Typically in the doctor's office you have it marked off on the floor with maybe a bright piece of duct tape or some paint, something on the floor. That way you don't have to keep measuring it every time. And that's what we're going to actually do the distance vision test with, is that Snellen chart. Then we also can do the assessment of near visual acuity, and typically that is done with the patient holding a piece of paper in their hand, and it's held at a distance between 14 to 16 inches from the eyes, and that's typically what you would use for reading maybe like a magazine or a book. So that's the distance that you need to remember for those two charts. So the Snellen chart we do distance vision with. We have our patient standing at 20 feet from the Snellen chart, and then with the near acuity we have the patient holding a piece of paper at about 14 to 16 inches away from their face so they can read that for us. Now, going back and thinking about what does it mean to see a visual acuity written down, you are going to write the results in the form of a fraction, and basically the top number is always going to be 20 if the patient is standing at 20 feet. then depending on how far down the chart the patient can read, that number will change. So if you're looking at the picture in the textbook, and I don't know why they don't have a picture in the PowerPoint, but that's okay. But if you look at line 8, that is considered 20/20, which is what everybody tries to be at. So that would mean that your patient started at the very top of the chart with E and read down all the way to line 8 correctly, not missing any of those letters. So what if they're reading line 8 and they miss one of those letters? Well, what you're going to write down for their visual acuity would be 20/20, or 20/20, minus 1, meaning they missed one letter. Now, if they missed 2 letters, then you would go back up to 20/25 for their results. So, and that's on any line that you get to. I'm just using 20/20 as the benchmark there. For most people, that's what they want to read. But if you go all the way down to 20/10, that's line 11. There are a lot of people that can actually read that far, but man, it is tiny. And another thing you want to do when you're measuring a patient's visual acuity, you want to keep in mind if they wear glasses or contacts, you need to write that on the documentation form. If they're wearing glasses, you might need to assess their visual acuity with and without, but that is very important that you note which one is with the patient's corrective lenses being used. You don't normally ask a patient to take their contact lenses out, but they can remove their glasses. Then we also need to check their color vision. Now on the Snellen chart, there are 2 bars. One of those is green and one is red, and typically that's the common thing to use for color vision, but maybe we have a physician that thinks that a patient is colorblind. So we would use another instrument called the Ishihara Test that tests for color blindness. And basically what that looks like is it's a circle with some different colored dots in the center, and as you can see here on the screen, typically there will be another number in a different color of dots within that big circle. So that helps us to know whether they have true color blindness or not. Men are more prone to be colorblind than women, so just remember that, and you probably have noticed that anyway. So what do you do as far as the procedure to check the visual acuity? You're going to check both of the eyes together. Then you'll have your patient to hold a paddle or maybe their hand in front of one eye, have them read the chart, and then the other eye. You never want the patient to press against their eye with either the paddle or their hand, because when they remove their hand and change to the other side, if it's been pressed against very firmly, then that will tend to cause the patient some eye irritation and they can't see very well. So we don't want to skew their results by giving them a false reading. So let's look at eye irrigation and all that fun stuff. So what's the purpose of doing eye irrigation? Well, we're going to clean out foreign particles. There might be some discharge that we need to try to rinse away, or the patient may have had some chemicals to get into their eyes. So a lot of times patients will come in because they've had some type of chemical to splash in their eye, and we need to flush their eyes out. And depending on what the MSDS sheet says will be the solution that we use. Typically it's just a normal saline solution. Okay. We also can do it to do the eye irrigation, that is, to relieve inflammation by using some heat and flushing. And then we also can do an antiseptic solution to try to work with the irritation that the patient has. So looking in your textbook, you need to be familiar with some of the other terminology that's related to the anatomy of the eye. Don't forget about the inner and outer canthus. That's the the part in the middle of your eyeball next to your nose that gets inflamed and itches sometimes. We really want to make sure that when we're referring to irrigating an eye, that we're going from one canthus to another. When we're draining that fluid, this is using a bulb syringe method. There's several different types of methods that you can use, but you want to make sure that you help to hold the patient's eyes open and give them some type of basin to hold underneath their eye once you're flushing the eye with that solution that you've made and the physician has ordered. There is also a pretty cool little device called a Morgan's lens that you can use, and basically it's an IV for the eye using a hard contact lens that continuously flushes the eye. And that's not very commonly used in the doctor's office, but if you work in an industrial and occupational medicine clinic, you might be lucky enough to use one of those. And then how do we actually instill eye drops? Well, as you can see in your textbook, and I hate there's not a slide picture to show you, but you do not want to drop the actual medication directly onto the eyeball. You want to make a little pouch with the bottom portion of the eyelid and drop the actual medication into that pouch. Or you could put that drop on the inner canthus and the medication run either medial to lateral or lateral to medial. But you don't want to drop the medicine directly onto the eyeball because it is very painful. Alright, so let's move into the ear, and we'll just do that real quick rather than starting a new presentation. Just hang on with me. Looking at the ear, we've got the big thing that the ear is responsible for is, of course, hearing, but it also plays a big part with maintaining our equilibrium or our balance. So we have the three main parts of the ear, which are the external, middle, and inner ear. This is a good little picture of the anatomy of the ear. Make sure you remember that. The main portions of the ear, but let's talk about some of the terms that you probably remember from terminology, but we're going to go over them again. But what is cerumen? How many of y'all remember what cerumen is? Remember, that's your earwax. And what is the purpose of earwax? Why do we need it? Why does the ear make it? Well, we need that earwax to help keep things from going in the ear, so it works as a protector, and it also lubricates the ear. We don't want anything dry anywhere within our body because those orifices need lubrication. So when we're looking into the ear with an otoscope, we're looking down to see the tympanic membrane, which is the eardrum. Remember, we want to see, how does that tympanic membrane look? Is it still intact? Is it torn? Is it bulging? All that good fun stuff. So the different ways that we assess hearing, we can use tuning forks, we can do a whisper test, we can use an audiometer and assess the patient's hearing. And what we're doing that for is to get a good baseline before we actually start doing different things, if they're coming in for an injury or what have you. So let's actually move on to looking at ear installation and irrigation. That's the fun stuff that we get to do. I love to wash out ears. It's pretty cool. But why do we do it? Well, we're washing out the external auditory canal with some type of solution. Typically it's a saline or a saline combination with maybe some peroxide in there, just to remove that cerumen or an impaction that's in there, clean out that auditory canal. Maybe we're trying to get a foreign body out, or to relieve some of the inflammation that's in there. So we're going to clean that out. So this is the reasons why we would do that. How many of y'all have ever used some heat to your ear, like when you had an earache? Yeah, that feels really good when you have an earache for some reason. So warm, moist heat there on the ear. What we want to do though when we're doing the ear irrigation and installation is we want to make sure that we don't do any damage to the internal structures such as the tympanic membrane. If you're going to instill drops into a patient's ear, the reasons we would do that is to try to soften up some cerumen so we can get it out. Maybe they have an infection and we need to put those in there to heal the infection, or maybe they're having some pain. But we're going to be sure to instill those drops very carefully so that it doesn't drop directly onto the tympanic membrane, because that can be just as painful as dropping eye drops onto the eyeball. So we want to position the patient to where those drops can run down the ear canal versus dropping directly onto the actual tympanic membrane. And if you'll look at the procedure for performing ear irrigation and installation, there's a step in there that really points out that you have to straighten the external ear, and there's two ways to do that. The first one is with your adult patients, which is you're going to pull the ear gently backwards and upwards for your adults, and then for your children you're going to pull the ear downward so you can see into that ear canal, because the way that the canal is organized and structured, it's kind of an S shape. So this is the best way so you can see down into that ear. Okay.